Hello and welcome to Conversations with Dr. Bachner. I'm so pleased to have Rochelle Walensky back. Hi, Rochelle.
Hi, good morning.
So Rochelle is the chief of the Division of Infectious Diseases and a professor of medicine at Harvard Medical School. Her clinical work is at Mass General. How's it been the last couple weeks, Rochelle? Has it gotten quieter in Boston?
Things are better in Boston. I mean, we're still, there's a lot of mask wearing in Massachusetts, I'm really happy to say. We have cases that number in the tens, not in the hundreds, and way fewer rule-outs of disease. We have just a handful of patients in our ICUs. So things are just so much better than they were the last time we spoke. Not the case nationally, of course.
Yeah, and we'll get to some of the public health issues, but you're an infectious disease expert, so I wanted to start with some of the questions that come up all the time, and I'm sure they'll begin to flow in. What's your sense about how the newer PCR tests are doing? You know, if you test when someone's there's these new notions of asymptomatic, pre-symptomatic, and then symptomatic. What's your sense about the sensitivity of PCR in those different phases?
You know, I think we still have a lot to learn about the asymptomatic and how it's going to work when we start doing surveillance. When we start looking at people who don't have suspected disease, we're screening, NBA athletes, pro athletes who were doing it for surveillance. When we start thinking about doing it on college campuses and whatnot, I think we still have a lot to learn about how these are doing. But I do think that they're getting easier. They're probably getting more sensitive. And I think even the less sensitive ones, the real thing that we worry the most about is somebody infectious. And so even if the sensitivity is down a little bit, perhaps that actually means that they're not particularly infectious either. And so I think we also have to sort of marry what we're trying to measure with, in terms of test sensitivity, with what we're trying to measure in terms of transmissibility. So if you weren't able to detect it until they had a viral burden that led to transmissibility, that's probably the thing that's most important.
Yeah, I know. We keep getting more and more information, and sometimes I think we're learning a lot. Other times I go, God, it's even cloudier now than it was a few months ago. I had Mike Osterholm on 10 days ago. Michael was great. He said, Howard, could you have me back in 2 weeks so I can correct all the mistakes that I've just made in my statements? I really appreciate it. Serology, IgG, IgM, neutralizing antibodies. The data I see is the vast majority, well in the 90% range, are developing IgG and IgM responses. Now, it's still a little unclear if they're all developing neutralizing antibodies and how long it will last. Is there any new information about IgG, IgM, and serology testing?
Yeah, I think a lot of the information is coming about that, and in a couple of papers recently that suggest that more people have antibody than we knew about, right? So if there's asymptomatic infection, we didn't test for them, it would stand to reason that some of these folks have antibody out there. So a paper in the Lancet demonstrating about a third of people in a really nice population sample in Spain had antibody and never suspected they had disease. I think we still have some challenges with the sensitivity and specificity. I think we still, as you say, have challenges with regard to how long if they have neutralizing antibodies, how long they last. I heard Tom Hanks on the news last night say that his antibody levels have been waning. So people who were, positive in March, what do their antibodies levels look like? And in fact, does that at all correlate with protection? I think people are getting anxious that if antibody levels are waning and it does correlate with protection, what does that mean for vaccines? Because we should assume that the antibody levels from true disease are probably higher than what we would get with vaccines. And so I think people are keeping a close eye on that, but I haven't seen much more than that.
Yeah, you probably know I had done live streams with Paul Offit and Tony Fauci, and Tony had made the point about both think that we will have a successful vaccine. When is less clear. Tony was more restrained about knowing how long immunity would last from a vaccine. He said really needs to see the data, and I don't think he's optimistic that it'll be 5 or 10 years, but time will tell.
But we do have vaccines annually, so like if we need to do that, we would do that, and that would be, as far as I'm concerned, a massive win.
Yes, that's true. A question's already come in. I'm not surprised. It's been on the front page of the newspaper. Droplets versus aerosols. To let people know, we have a very important viewpoint coming out by Michael Klompus on Monday about this issue, who's making the case for why aerosol spread when you have good ventilation is likely unlikely. But I'm curious about your viewpoints about droplets versus aerolization. Droplets larger, aerolized particles smaller, they float in the air and then they float around. But your sense of droplets versus aerosol.
So this is complicated. So the real issue is the size of the particle, as you talk about, as you discuss, droplets being 5 to 10 microns, aerosols being anything less than 5 microns, and the assumption that they're actually mutually exclusive, right? So most respiratory viruses are droplets, and we believe that this one is droplets. However, there have been enough studies now and enough cases situations that have demonstrated that there's probably some aerosol in there as well. It's not just big particles, it's some small particles too. When you get small particles, they stick around a little bit longer, and they could float for a little bit longer. They could float for a little bit further. So the cases of the choir practice in Seattle, 52 people infected, the restaurant in China where 3 family clusters, but all of those have been in poorly ventilated, crowded situations. And so what this letter to the WHO discussed was doing something about ventilation, about air filtration, HEPA filtration, and about decreasing crowding. I want to make the important point with regard to this, that when we in healthcare think about droplets versus aerosols, we think surgical mask versus N95. And so I just want to be clear that this does not mean we all need to walk around in N95s. And that, I think, is a really important point to make. And the letter, even to the WHO, did not ask for N95s. It asked for more ventilation, air filtration, and decreased crowding.
Yeah, Michael makes that point in the viewpoint that we're going to publish on Monday, with his suggestion that droplets is still the primary route of spread. And aerosolized, I'm being corrected about my pronunciation, which I don't mind at all, may occur but less common, and ventilation appears to be the key. Yeah. So it looks like a couple treatments have emerged. The steroid story in recovery is confusing because no one's really seen the final publication. Seems to have worked in some groups but not others, and it may have done harm in some groups. So we have steroids. Remdesivir has been out for a while. Some unusual studies, one positive, one not positive, no mortality benefit, sample size issue. Chloroquine's dropped away. We and a couple other journals have published studies that have really suggested no benefit. And then JAMA's published a number on convalescent plasma. Small RCT had to be stopped early. Overall, no effect, but subgroup analysis showed nice benefit. So how are you thinking of these, remdesivir, steroids, convalescent plasma?
Yeah, I mean, we haven't seen a ton of data, RCT level data on convalescent plasma, and I think both the IDSA and the NIH guidelines suggest that we still need to be looking at that in the context of clinical trials, and I know those are still ongoing. The remdesivir, as you note, is kind of to, I think, quote Dr. Fauci, is a solid single, but not a home run. Yeah. But right now, it's kind of one of the best things that we have for people who are not quite as sick as meriting dexamethasone. So in my mind, this is sort of a continuum. You come to the hospital because you have, you need oxygen. That's kind of the time to use the antiviral before you have all the inflammation, and probably less of the time to use dexamethasone. If you progress to a place where you're really super sick, you have the inflammatory immune responses that land you in the ICU, that's probably the time to use the dexamethasone. And in fact, that by press release anyway, that has demonstrated a mortality benefit that we haven't yet seen with remdesivir. one thing that's important to me is sort of how the access and cost to these drugs. So dexamethasone is cheap. It's probably less than $50 for the 10-day course that was used in these trials. It's accessible. Everybody can get it. Remdesivir, less so. We have only one company making it in the United States, and they have the exclusive patent for it. And, we have, I think, 500,000 courses are expected, but we have a lot of disease coming. And so, we don't necessarily want to be in a place in this country where we're not accessing one of the major drugs, that is available to perhaps not be the home run, but to do something to help. If it does decrease, well, the studies show that it decreased duration of illness. As we have overwhelmed hospitals, I think decreasing the duration of illness is actually key to get some people out of the hospital so that more people can be in it.
Rochelle, so, you saw a lot of patients when the general was particularly busy. And when I did my live stream with Mauricio and Derek Angus, Mauricio Ciccone and Derek Angus, we talked about different phenotypes. And I was struck by your comment early in the course, you may want to treat with this drug, later in the course with that drug. To me, it also would not be unusual if we didn't see different phenotypes. Now, whether you can marry that to a specific treatment, but questions of timing of treatment, which treatment, and then combination treatments have come up. Do you have any instincts about that? I know there's no published data, but do you have any instincts about that?
I would say right now we're still in a pretty blunt course here. We don't really have those phenotypes to understand them. There's a lot of conversation also about strains that have emerged from Wuhan versus strains that have emerged from Europe. So not only might we think about it from a patient level, but also from a viral level, should we be understanding which strains would certain drugs be better for other strains? The other thing I think that is going to be really key in this, current surge and next wave is understanding what we can do in the outpatient, right? So much of our trials have focused on the patients in front of us in the hospital. But what we really need is outpatient regimens to prevent them from coming in the hospital, and not just to prevent them from coming in the hospital, but to prevent their viral burden. Because if we can actually decrease viral burden for people who are infected, we might be able to decrease transmissibility. And that, I think, would be really key.
Do you have any sense of what therapies may be effective for prevention, or at least prevention to critical to needing hospitalization?
There are trials with Camostat. There are trials with, I believe, some monoclonal antibodies, and trials, I believe, that are starting to come look at inhaled or nasal spray remdesivir. So I know things are coming down the pipeline. Unfortunately, it looks like we're going to have plenty of patients to do these trials in, though we're trying hard not to have them.
There's a question about interferon. We've had probably 50 or 60, 70 different proposals. I mean, the other drug that comes across my desk all the time besides interferon alpha is Toci, or one of the IL-6 blockers, and there's a few of them. Did you use it at the General? Do you have any instincts about that?
We have just completed a clinical trial with Tocilizumab, so I haven't seen the data. There are several camps in this. There are some folks who really, it's never worked that well for other causes of ARDS, and so it's not entirely clear that the intensivists who have a lot of experience in trials with ARDS, it's been helpful. Whether it will be helpful but there are some people who have used it and will swear that the reason their patient got better, the reason their patient avoided long-term intubation was because of the Toci they got. I think we really do need some of these clinical trials. I do know a lot of people who very much believe in it, and I'm really anxious to see the results of these trials, one that just completed here.
Yeah, it's interesting because, all of the patients have virus. So if you give remdesivir, theoretically, it's affecting viral load. Not everyone has a large inflammatory cascade as measured by, for example, D-dimer or C-reactive protein. So I can imagine that Toci and Toci-like drugs will work in a more select population. The question is, are we wise enough to be able to know who that individual is? And that's less clear to me.
And we have the ability to look at IL-6 levels. And so we've been following some folks who have like really escalating IL-6 levels as we're watching their D-dimers climb, their CRPs climb and whatnot. And those are the ones in which we would target the Toci, I would imagine, almost similar to the dexamethasone, right? People who have that heavy inflammatory response are the ones that you wanna dampen it down.
So let's change directions a little bit. It's not been a great week at all for the United States. At the peak in New York City, we were at about 30,000 cases. Now we're well into the 40s, low 50s. I think some people are predicting high 50s, low 60,000 cases. Now the number of deaths are lower. That ratio is lower. I think that is good news. Is it a failure of social distancing? Is it a failure of masking? I finally feel like there's a sense that many people, many leaders in government, both Republicans and Democrats, although Democrats have been pretty clear from the beginning, are finally beginning to acknowledge we took a turn and we didn't go in the right direction. What's your sense as an infectious disease public health expert?
Yeah, so I've been watching the numbers carefully. The first thing I think to recognize, and I think we did actually hit 60,000 yesterday, when we shut down and sort of were in stay-at-home orders in March, we were at 15,000 new cases a day. And so we're now at 60,000 new cases a day without those stay-at-home orders. Yes, some states have pulled back some have closed the bars, but we're not nearly at the stay-at-home orders that we were on March 22nd. And it took until April 24th to see our peak. So I think we're nowhere near the peak that we're going to see, as much as that pains me to say. I also think that 60,000 is probably the tip of the iceberg, because you look at the snakes of lines on the news of people waiting for their tests. You understand that, people have a 7 to 10 day wait once they've actually been tested. And you realize that we probably are unaware of many of the tests, many of the positives that are out there. I'm worried. I think the deaths, I think it's a little bit of a false sense of security to say that the deaths are down, because we know that it takes a while for these people who test positive to reach medical care, to feel sick enough to, increase their oxygen need, to get respiratory distress, intubated in the ICU, and then ultimately pass when they do, God forbid. But it's also the case that the average age of people who are testing positive is younger. Right. So perhaps that bodes well for the mortality here, and that it won't spike as high as we thought or we saw before. The flip side of that is, if those young people who are testing positive are not wearing the masks, not doing the things that we know will help prevent transmission, and are simply transmitting it at 2 to 3 times the number of people, then we may see those peaks in older people. I worry about states like Florida, where 25% of the population is over the age of 60. And so I think we have yet to see how this next or continued surge in some of these spaces is going to fall out in terms of deaths.
Yeah, the data have been so overwhelming from the early epi reports at all of the journals published in February. At some age, you can pick it 60, 65, or 70, your risk skyrockets, healthy or not. And so we know who we need to protect. I mean, the most recent estimate is that 40 or 50% of the deaths in the country had come from nursing homes or nursing home-like facilities. So I'm hoping that we've learned over the last 3 or 4 months. If you're a young person, you and I have talked about it, we have young men and women as our children. They should do fine if they get infected, but they can infect other people, and that really becomes critical. I was watching a famous baseball player. He was wearing a mask, but none of his teammates were wearing a mask, and I felt like going, it's nice that you're wearing a mask, but if you don't want to get infected, you have to go tell all your teammates not to wear the mask. It's this odd notion that people really think they're protecting themselves when they wear a mask, and they may be a bit, but not that much.
Right. Well, and the other thing I want to emphasize is it's true that the mortality is so much higher in people who are 60, 70, and 80. But we're now at really high numbers of cases. So like if we have 60,000 cases per day, and even if the mortality is 0.5%, that's 300 young kids, right? And we're seeing that in the Penn State student, Juan Garcia, who passed over the weekend, in Nick Cordero. Like, we are seeing young people pass from this. And that's not just statistics. I mean, maybe it's just, doing the multiplication. But to imply that the young people are going to be fine when we have such huge numbers of people who are getting infected every day, we're going to hear a lot of young people who aren't fine.
Yeah. There's no safe infection with COVID-19. And if we do get to 100,000 cases, there will be deaths, and there'll be deaths of young people. So let's turn to two other topics. Both have emerged in the last week or 10 days, and this is besides aerosolization, schools and colleges. We published a paper almost 3 weeks ago about opening schools because we thought it was so critical to initiate the discussion. It's now become a national discussion. President Trump addressed it yesterday. And then we both have young adults. My kids are done with college, but I've watched many of our associate editors have young adults who may or may not go to college. But let's start with schools and then move to colleges. You and two other co-authors have an article coming out in JNO. I know you mentioned it's up on medRxiv. Assessment of COVID-19 screening strategies to permit the safe reopening of college campuses. But let's first start with schools. 55 million children under the age of 18 go to school. I think people have begun to recognize keeping them out of school for an entire year. There will be consequences, trade-offs. How do you think about opening schools, not colleges?
Yeah, I think, in this era, first of all, you're right. Everybody's worried about this. In this era, we've spent so much time worrying about what happens because of COVID-19 and the deaths and mortality and infections related to COVID-19 that we have not looked at the counterfactual of what's happening to the kids in the absence of schools, the domestic violence, teen pregnancy, food insecurity, lack of education, parents not being able to work. There are so many negative effects of not having the kids in school that I think now we really have to understand and weigh those. I think kids can wear masks. My kids have been wearing masks. I know very young kids who have been wearing masks, and I think we can do this safely. I really believe we can do this safely. I think kids tend to do really well with this disease. Now, the problem with saying that is the kids go home and they sort of have the potential to infect an immunosuppressed parent, a grandparent who may be living with them who may not do so well. So I think we really do need to understand the ramifications of what we're doing, make sure that the kids are wearing the masks, the teachers are wearing the masks, that there's a lot of policy and regulations and education about how to do this safely. But I really think that we should be motivated to try and get the kids back. The other thing I think that's really important is we have to look at the local trends. Do I think kids should go back into school in Florida today with a 25% test positivity rate? I don't know that it's viable in Florida. Is it viable in communities where you have, like Massachusetts, where our test positivity rate is 2%? I think we can do it. I really do. We'd have to look at state by state, but I think before we make these decisions. Yeah,
that's come up before, that one size may not fit all, and it may vary. I happen to know that someone was going to have a student at USC, and it was going to open 2 weeks ago. Now they've looked at the LA data, and USC will at least not open in person now. I wouldn't be surprised if that changes for January of next year. So I do think one size does not fit all, and I think we really are uncertain what the fall is going to bring. Let's put that aside, and we'll return to one or two of the issues about the fall. Colleges on the front page of the newspaper almost every day. Different schools making different decisions. My understanding is Colgate's going to open. USC is not. Harvard made some decision yesterday. MIT made a different decision. All over the place. You've written an article. What's your sense about colleges?
Well, I was called out on Twitter and told that I have a conflict of interest. So I will just say it out
Please
there.
Declare
I have two kids who go to college,
right.
and I want to be able to go. I will say, I think it's possible. I think it needs to be accompanied by behavioral intervention so the kids stay safe. We have to keep the RT down on college campuses. We can't have super spreader events. Kids want to come back. They want to interact with each other. If they're doing it in masks, it's probably safe. If they're doing it not in masks at a party, it's probably not. So, but I think the kids are actually motivated. I know they're 20-year-olds, but I think the kids are actually motivated to go back to school and motivated to keep safe. So one that is in our control is to make sure that we can keep the RT down on the college campuses. The other, I think that's really key is testing. And I mean a lot of testing on these college campuses. We've demonstrated in the manuscript that you're talking about that if we have an RT of 2.5, which is high in the context of wearing masks, is probably the R naught of not wearing masks, right? If we have an RT of 2.5, we should be testing about every 2 or 3 days to be surveilling our student body, a residential student body, to make sure that we don't have outbreaks. And this is sort of acknowledging that kids will go off campus, they will ride the T, they might be involved in a party, that there might be these sort of exogenous attack rates that come in much out of your control. And you really need to be able to identify them quickly with testing. So I think it's very doable, but we sort of demonstrate that in a modeling study that you'd need testing about every 2 or 3 days to be able to really control these attacks and keep your positive rate quite low.
Do you think, Rochelle, that just like with schools, decisions for urban campuses may be different than for semi-rural or rural campuses? I mean, Boston has 150,000 college students, but, BU may make a different decision than BC or Emerson or MIT, but that may be different than Wesleyan or Union College. That's more rural, the main schools. Do you have a sense it may vary?
I think that's actually a really important point because I think it should and has to vary. So, people who are riding the T between BU and Wellesley or BU and MIT, they're going to sort of have the community of Boston, potential infection rates. If you're able to be at a school like Vassar, where you can test people coming in, they don't mix very much with the outside community, they don't mix with other colleges, they're not riding public transportation, it's generally kind of a walled off bubble. So in that situation, your RT actually might be driven down to, let's say, 1.5. And if it is, or even less than that, if it is, probably weekly testing would be absolutely fine. What we really worry about is if you just wait for symptom-based testing, things can get pretty out of control pretty quickly, and you would not necessarily be able to identify an outbreak before it happened. So I do believe that you might need every 2 or 3 days in an urban city like Boston, and maybe weekly in a more rural community like Union College. But, I do think that we need some sort of surveillance testing, or we have to get really darn lucky.
There's so much unknown about the fall. I mean, the first is this notion of waves. Mike Osterholm commented he didn't think we really have waves. We have constant drip, 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 certainly in the U.S. I think other countries have done a better job and have had a big wave and then little ones. That's less true in the U.S. Do you fear for the fall? Flu, indoors, ventilation is a problem. Do you have a notion of what the fall will bring or what we need to do?
Yes. I fear for all of those things. One of the things that I have been saying to our local community and to our government is we need a massive flu vaccine campaign. Yeah. I think people really don't realize how stressed our ICUs are because of flu in January or in February when we really have a lot of flu. Our ICUs are full, even without COVID. And so we don't have a lot of buffer for COVID should COVID come in the door in another peak. And so I really firmly believe that we need to sort of mass vaccinate vaccinate for flu to try and keep as many of those, which we can do, to try and keep as many of those patients well so that we have enough beds for our COVID patients should we have another wave. I mean, all of the things are, potential is going to happen. I don't think we're going to be dampening this surge in time for September. The weather is not going to be as good. We in the Northeast are probably going to be indoors more. The air will be drier. All of these things that sort of make a perfect storm for respiratory viruses like both coronavirus and influenza virus. Interestingly, as I think about getting indoors in the fall, one of the things that's been intriguing is, a lot of the places that have outbreaks now, like Florida, Arizona, Texas, are places where they're indoors in the summer. It's too hot to be outdoors. And so not only are they indoors, but they're indoors with a lot of air conditioning. And so that may be propagating things in some of those really hot places.
I'd like to return to a few of the questions. I know it's been almost 35 minutes, but you're such an engaging guest. Do all those people who are standing online to be tested need to be tested? I'm curious about that. I mean, I saw the lines last weekend and probably this past weekend, although I didn't see it was July 4th. But do all of them need to be tested? Because my friends often ask me, should I go be tested? And I often ask the rhetorical question, what is it that you're trying to find out? So who should be tested?
Right. I mean, I think if you have enough tests, then you should be testing people with any sort of symptoms at all or any sort of exposures at all. The exposures are really difficult because if you told me that I was exposed to somebody yesterday who had COVID, I could go get tested today, but I haven't sort of lived through the incubation period, so I might be fully reassured that I was negative, and I think a lot of people are. But it's not clear to me as I look at those lines how they're managing the strategy or the triage of who gets tested, because you have a lot of well-looking people in these cars who are saying they've spent the night in their car waiting for their test. And in my mind, if they're shutting down testing sites and running out of test kits, we really should be triaging the people who have symptoms, the people who are feeling unwell. And so that is entirely unclear to me how you end up with lines like that. I know when we were in pretty dire constraints with tests in Massachusetts, and I actually needed to be tested, I got an appointment time. I drove in, I got tested, and I drove out, and the whole thing took less than 5 minutes. So it does seem to me that there are some operations in that might facilitate triaging tests to the people who need them the most.
Yeah, I want to remind people, this has come up repeatedly, and we have a long clinical review being published on Friday. It's written by 5 different physicians from around the world. It's really interesting. But, incubation period is 14 days. But most people, if they're going to be exposed and then positive, I think they quote 97.5% are positive within 8 days. So if you've been exposed and you're well for 10 or 12 days, you likely don't have disease and you may not need to be tested. I do travel periodically to see my family, but I do it every 2 weeks to make sure I'm well in between. I don't get tested each time. If I were to get sick, I would get tested. But I know if I'm well for the 14 days, I theoretically I don't have disease and can't communicate disease. A question about herd immunity. There's the great Swedish experiment that has not gone well. 330 million Americans, herd immunity, the low end is 60%. That would be close to 200 million people would need to be infected to get to herd immunity. Any sense if that's possible in any country in the world?
I think people want to say that so many people have been infected and therefore we're getting close to herd immunity. I mean, we've had 3 million people who have had documented infection. We are nowhere near running out of Americans to infect. And even the CDC, which has said we're probably at, we probably have detected only 1% and 10% of people have had infection and probably have antibody. So, we're at 30 million people who've been infected and we still have 300 million people to infect. So, I really hope we don't get to herd immunity by infecting people. And I hope we get to it by vaccine instead, because that would be a way better, safer, less mortality outcome. But no, I don't think we're anywhere close to herd immunity.
Right. There's also another question about how long it would last if you get infected. If we don't know those data, But the reality is people who were infected in January, February, or March in the New York metropolitan area, they may be protected, but it may only last for 3 or 6 months. So you don't want them to have to be reinfected. I feel like I should give you a chance to comment on vaccines. I have talked to both Paul and Tony about it, but and we had a nice paper by Paul Offit go up yesterday about the 5 warp speed, although there's many others. A little unclear about Moderna has announced a bit of a delay. It's a little unclear why. Are you optimistic about vaccines? Not optimistic? Really want to see the data?
I don't love doing science by press release. It's just, it's been really hard to understand why things, and I understand some of these studies are actually coming out. How could you not be optimistic when it's moved so quickly? But at the same time, I think we have to be grounded and realistic. I think we will have a vaccine for this disease faster than any other we've had. Do I think it's going to be by January? I'm not particularly optimistic for January, but I am optimistic that it's going to be fast. I think the real issue when we have a vaccine, A, is going to be production. Will we have enough of it for the people who need it? B, it's going to be cost. Will people have access to it? Because once we have a vaccine, it probably could be priced at whatever, the company wants. And I'm very, very worried about that. But then also, a lot of these vaccines have that we've seen the data for, have a reasonable level of side effects. Many have, fevers and myalgias as one of the side effects of taking it. We know uptake of the flu vaccine in a good year is around 45-50%. And we need herd immunity. We need 60-70% of people to take this vaccine. So I'm worried about the pipeline of it getting to everybody who really needs it for all of those reasons.
Last question, and I can't thank you enough for your time. Each week brings a different issue. This week it's been this aerosolization versus droplets. Last week it was, who does steroids work with? Some concern that the virus has mutated. And in fact, I know there's enough genetic imprinting or knowledge to know that the infections on the East Coast are very different than the infections on the West Coast, at least where they originated from. Not surprising because of travel. Many more on the East Coast have originated from Europe and not Asia, and West Coast is more from Asia, less from Europe. Do you have a sense, reading through the literature, about genetic shift, mutation, how concerning it is? Will it affect either treatment or vaccine development?
Right. My understanding, so yes, just as you say, more of the virus on the West Coast has been what they're documenting from Wuhan, and a genetic mutation in the virus, in the spike protein, looks like it is the European strain. It looks like from the literature that the European strain is more transmissible, that it is more easily transmitted to other people. And that may be why we're seeing way more European strain now than we saw than we are seeing the Wuhan strain. My impression also is that it has not led to increased mortality or it's virulent in terms of its ability to transmit to other people, but not necessarily in terms of different outcomes. I don't believe there are any data to suggest that our treatment for it would be any different. Generally, when these viruses mutate, or that our vaccine against it would be any different. Generally, when these viruses mutate, lost my thought there. But so I don't necessarily think that that the mutation is going to, I know what it is. Generally, when these viruses mutate, they do so in a way that it makes it more fit for them, but perhaps leads to less mortality. So maybe in its transmissibility, we will increase transmissibility. We will see less mortality associated with it. Although it may be that we're too early to sort of detect that. So I think again we're just at our instruments are blunt. It's dexamethasone and remdesivir. That's kind of all we got right now. So I don't think we're even yet in a position to say this targeted therapy for this strain of this virus, that targeted therapy for that strain of this virus. I guess we're going to get there over the months and I hope not years ahead. But I think we're with this virus for a while, so I think we're going to start seeing some studies in those spaces.
This is Howard Bachner, editor-in-chief of JAMA. It's been Conversations with Dr. Bachner. I haven't said this for a few weeks. I so respectful of my profession. I really, once again, want to acknowledge healthcare workers worldwide and the people in grocery stores who keep allowing me to eat, and people who deliver packages. In that regards, many people around the world have really rallied to help others. And I hope people can think about wearing masks so that they can help others. I think it's something that people have begun to really talk about, that we do have social responsibility to protect other people, and it's very clear that that does. My guest has been Rochelle Walensky, who's such an engaging guest, and she's a professor of medicine, chief of infectious disease at Mass General. Rochelle, thanks for joining me today.
Thank you so much for having me and for all you're doing.
Stay healthy and be well.
Take care, you too.
Bye-bye.
Bye.